Been a slight change of program. We shall proceed with the orations now. Okay. We shall begin with the Professor Bimalendu Mukherjee Memorial Oration, which will be delivered by Professor Sabnis. May I now invite Dr. Kullan Kumar Shorkar and Dr. Gopalakrishnan to kindly come up on stage and chair this session. Sir, please.
Good afternoon. The next program is the prestigious Professor Bimalendu Mukherjee Memorial Oration, and this will be delivered by Dr. Ravindra Sabnis, Chairman, Mukherjee Patel Urological Hospital. May I invite him to the desk? Dais, please. May I now, it's my great pleasure to introduce Dr. Ravindra Sabnis to you. He is currently President of the Urological Society of India and heading the Department of Urology at the prestigious Mukherjee Patel Urological Hospital, Nadia in Gujarat. He has completed his MBBS, MS General Surgery and MCH Urology in 1988 from the esteemed Lokmanya Tilak Municipal Medical College in Sion, Mumbai. Then he continued to work at the same place as an assistant professor. Later, in 1992, he moved to Mukherjee Patel Hospital, Nadia, and started working as a full-time consultant. In 2010, he became chairman and head of the Department of Urology in the same institute. He is an excellent surgeon, a passionate teacher, and distinguished leader. He is the main man for organizations, from being treasurer of Mumbai Urological Society to secretary of USI and president of USI. At present, he has served the Urological Society on every front. He has received honorary membership of Nepal Urological Association and is a visiting professor at Hamad Medical Corporation in Doha, Qatar. He is a most dependable surgeon for his patient, a revered teacher for his students, and a very popular leader in the USI. He takes keen interest in teaching, attends various academic activities across the country with zeal and enthusiasm. He has made more than 250 presentations in various national and international conferences, more than 200 publications. He is an author of one of the most popular books on urological instruments and written many book chapters. He has been the resource faculty for many live operating workshops. He has received DNB Teacher Award in 2019. He has also received Global Leadership Award from the American Urological Society in 2020 for his contributions as secretary to the USI and on strengthening ties of the USI globally. He is also recipient of the President's Gold Medal 2021. Gentlemen, many of us who have been in peers for the last 25 years, we have grown up together with Ravindra Sabnis, and we have the greatest of admiration for his abilities. So may I now request him to come up and deliver the Professor Bimalendu Mukherjee Memorial Oration.
नहीं ये क्या हो रहा है नहीं ये डाउनलोड हो रहा है Well, thank you, Dr. Kalyan Sarkar, for that very kind introduction and very elaborate introduction. And I must thank Dr. Gopal Krishnan for inviting me and making the part of this particular meeting. And I must also thank the whole Bengal Urology Society for inviting me for this prestigious oration. Well, Dr. Bimalendu Mukherjee does not need introduction to this August gathering, but as a customary and as a protocol, I'm a very small person, but I would like to introduce Dr. Bimalendu Mukherjee to this particular audience. He was born in 1929. He had a very brilliant academic career. He went to UK way back in 1956. I think majority or most of us were not even born at that time. And he stayed there for 5 years till 1961. There actually he got exposure to urology, as many of the senior our teachers who got trained in urology when they were in UK. And when after getting that training, he came back and joined as a professor of surgery in Calcutta Medical College. As you know, at that time, there was no separate branch identified as urology, and therefore he was joined as a professor of surgery. But having impressed by the work of urology in UK, he always wanted to make a separate department, establish that specialty at that time, and he made a lot of efforts to establish that department in Calcutta Medical College. And subsequently, we know that there are so many other teachers and students who have got benefited with the struggle that he made at that time. He was instrumental in starting MCS program in Calcutta. And now, as Dr. D.K. Pal sir said, that there are so many students which are now getting the postgraduate training in Calcutta. Once the urology was separated, he was a guide to many students. And then he got a lot of interest in organizations and various associations. He was very enthusiastic. He occupied various positions in Bengal Urology Society, East Zone USI, and finally got elected in the top slot as the president of USI in 1996-97. He died in 2007, but his name will always be remembered when we talk of history of USI, as he occupies the most coveted position amongst the galaxy of past presidents of USI. So that is Dr. Bimalendu Mukherjee, and I have a great pride and pleasure to deliver the oration which goes by his name. Today I'm going to talk about the troubleshooting in RIRS. Well, when we talk of this, why this particular topic for oration? There are many reasons for that. RIRS has now seen the exponential growth, especially in last 3-4 years. It has grown very, very rapidly. Why is that? Because incidence of small stone has increased enormously. The kind of staghorn stones and large buck stones which we were seeing in 10-15 years back, now hardly ever we see. Because there is a lot of awareness, people come forward, get treated. There are various schemes which are available, and therefore a lot of small stones are picked up, and that is where RIRS has become a very important tool for them to treat such patients. ESWL, which was a mainstay 2 decades back, is actually gradually disappearing, and at many places, in fact, it has disappeared. In our hospital, at one time, we were doing about 7 to 8 cases of ESWL per day, and now in last 7 months, we have not done even single case of ESWL. So ESWL is going down. And looking at the trend all over India and all over world, the RIRS is increasing. Whatever which is compensated by the loss of ESWL actually is picked up by the RIRS. And if you see in last few years, there are a lot of developments and research which have come in RIRS from the laser, from the sheath point of view, from the size point of view, from the optics point of view. And therefore, RIRS has actually become a mainstay of the management of stones. When we talk about troubleshooting, what is the meaning of troubleshooting? In simple words, it's a troubleshooting skills are the problem-solving abilities of a person. The ideal troubleshooting skills means you begin with gathering maximum information to define the actual problem and provide the best possible solution by generating and evaluating all possible solutions. So that is troubleshooting. I'm not going to give the lecture on the complications and indications and what will you do and what are the tips and tricks and things like that. But what are the common problems which you come across and how to overcome those problems? That is what I'm going to deal with this, because that is where it will be used for the people who are starting RIRS, those people who are doing RIRS, it will be useful for them. When we talk of RIRS, the first and foremost difficulty which comes often is identifying the orifice. Now, many times you will find that when you want to take up the patient for flexible ureteroscopy, and when you go into the bladder, you find that the other orifices is all right, but the orifice which you want to cannulate looks like this, and you don't know what exactly to do. There are so much of edema which is there, there are so many pseudopapillae which is there, and orifice is not identified at all. This happens often when there is an impacted ureteric stone and you want to do ureteroscopy along with the RIRS, when there is a previously just past a ureteric stone, when there is a bullous edema which is present there. So how to overcome this problem? So how to troubleshoot this? When you see like this, first give a lot of fast IV fluids, give Lasix. Methylene blue takes time and therefore most of the times it is useless. You take small ureteroscope and with a little bit of a pressure irrigation, look at the site of the orifice. 4.5 French URS becomes very handy in such a situation. And generally when there is a lower ureteric impacted stone, these are the situations which you encounter. So how to overcome that? So when we see that, okay, ureteroscopy, with the irrigation pump, a lot of fast irrigation, you look at the site where there is likelihood of ureteroscope orifice, and with the ureteroscope, you'll always find that there is some opening-like thing which is seen, which is amongst the bullous edema and the pseudopapillae. Try to cannulate that. With the irrigation which is going on at a little faster rate and with the pump, you will find that gradually this edema and the papillae, they separate out, the orifice becomes visualized, cannulate that orifice, and that is how you enter the ureter. Here you find that when you, as soon as you enter the ureter, the problem was that there was a lower ureteric stone that was dealt, and then subsequently RIRS was carried out. So that is how you troubleshoot this problem. The next problem comes, there is a lot of kink. This you will encounter very often, that when you take up patient for ureteroscopy and you find that there is so much of a kink that you really can't negotiate even the glide wire. So how to overcome this problem? What you are doing is you are applying external pressure here. So what you do is that with the external pressure, try to manipulate in such a way that kink gets straightened up. Often you will be successful and your wire will go away. Use a new glide wire which actually goes very easily and takes up the situation and goes it. If the glide wire goes in, try to pass a ureteric catheter. If it goes in, then naturally this kink will become straightened up. If that doesn't happen, then what you do next is that take a bigger size dilator, pass up to the kink and then pull it down. With that, the kink gets straightened up and then your wire and everything will go away. If all that thing is not successful, then what you have to do is what is shown here, is that you take the flexible ureteroscope itself and then try to manipulate. You will be successful if you have a patience, if you have the proper vision which is there. Now here what is done is that you take a flexible ureteroscope, see under vision where exactly the curve which is taking place. Initially there will be difficulty, but as you keep on forwarding and bending and making the movements, putting the pressure from outside, you will find that gradually you will be able to negotiate the ureteroscope in the kink, and then you will be able to put the ureteroscope inside the pelvic calyceal system. Here you can see that this is what was manipulated. The wire becomes very handy. Sometimes the super stiff wire is very helpful because that straightens the kink very much. And with little bit of a manipulation here, you can see that opening, negotiate the ureteroscope there, go where exactly the lumen is, follow that lumen, follow that wire which has gone inside, And then you manipulate your ureteroscope in such a way that eventually you reach the upper calyx where the stone was there. Now this is where you have negotiated successfully, and now you see that the stone is visualized, and once your stone is visualized, start breaking the stone. The important thing here is that when you had difficulty of negotiating the ureteroscope, don't try to take out the ureteroscope once you start breaking it. Just keep on breaking and ensure that the whole stone is broken properly, and otherwise you will end up with the same problem negotiating and spending time again. So that is how you do it. Next problem comes, and next trouble comes about the ureteric dilatation. Often you will find that you take up the patient for flexible ureteroscopy and you realize that ureter is not getting dilated. This will happen in about 30% of the cases. That is the statistics, that 30% of the Indian ureters are not able to dilate, and you will not be able to put an access sheath, and you will not be able to do the ureteroscopy. So what you do in a situation like this? Do serial dilatation. Don't just take one single step dilatation, but start from 6, 8, 10, 12, and then often you will be able to succeed. Sometimes many of these urologists, they will pass a semi-rigid ureteroscope, 7 French or 8 French, and see whether you can negotiate that or not under vision. And once you pass a semi-rigid ureteroscope, the ureter gets dilated and subsequently the access sheath goes. Important thing is that never force. Even whether it is ureteroscope or dilator, important thing is never force. Otherwise you will end up in problem. There is no harm in doing 2-stage procedure. There is no harm in coming back and telling the relatives that this was not possible. We'll wait for 2 weeks and then we'll come back and do ureteroscopy successfully. How much time to wait? Sometimes 2 weeks actually is the ideal time. If you do too early, there is not enough time for ureter to get passively dilated. If you do too longer time, then patient may end up with fever and other problems, and then again it gets delayed. But what we have found that 2 weeks is the ideal time where ureter gets dilated passively, and at the same time problems and complications of long-term DJ are not there. Now, having dilated ureter, there are few more things which can happen. That you have dilated ureter successfully, but the access sheath is not going. Now, that is quite often that trouble comes in. So what to do? If you are actually dilating, and what kind of access sheath which you are using, you should dilate 2 French more than that, so that the access sheath goes easily. Often we reuse the access sheath. If it is an old access sheath, it becomes quite flexible. It loses that rigidity and the smoothness. And therefore, you will find that problem of putting the access sheath which is reused or which is old. But if you take a new access sheath, often it goes very easily. Use smaller access sheath. If you have a smaller ureteroscope, then better that you use smaller access sheath, as smaller access sheath will go easily. And if it is still not going, then you have the option of putting the ureteroscope directly without access sheath. And if that also is not possible, because the tip of the ureteroscope is such that sometimes it does not get negotiated through the orifice, then it is better that you stage the procedure. The next important thing, and many times we come in trouble and in problem because of vision. Now in ureteroscopy, especially in flexible ureteroscopy, the vision is very, very important. And therefore just gravity irrigation is not sufficient. You need to have some sort of a pressure irrigation, because the flow of the fluid from the ureteroscope is very less. The channel is very small, and therefore pressure irrigation is required. You can use pump. These are all locally made available pump. You can use Euromat or local pump. You can use Pathfinder. You can use the person who is actually pressing the bottle, BP cuff, and all those things are there. Manual syringe, something can be done which you can get used to it, but that pressure or that little bit of a more irrigation certainly required to have a proper vision. If you have a proper vision, no problem, your success will be high. Next problem comes that you want to do ureteroscopy. It's a lower calyceal stone, and what you come in trouble is that with the basket, it is actually not coming out. Now, this is a very common problem. You want to relocate, but it is not getting relocated. Basket is not getting engaged into the stone. So what you do is that sometimes there is a disparity of the basket size. If it is a smaller stone, you better engage type of stone. If it is a bigger stone, then you better encircle. So depending on the size of the stone, use that type of a basket. Often there is not much space in the calyx, and therefore the basket doesn't open up. And when it doesn't open up properly, obviously it is not going to engage the stone, and you will not be able to relocate it. Sometimes there is a narrow infundibulum which prevents it coming out. And sometimes there's a vertical orientation of a calyx, which always is a problem. Whatever procedure you do, it will not come out easily. So what do you mean by vertical orientation of the calyx? You see this calyx, this stone. If you see if you want to do ureteroscopy, then you have to pass a ureteroscope like this, like this, like this, and then actually come vertically down. And when you have such a compact stone into the vertically oriented calyx, relocating that stone always is a challenge. And that's our biggest trouble which you come across. So what do you do? Now this is what happens when you have that sort of a sting. Here you can see that you enter the system, you see the calyces, you bend your ureteroscope to go into the lower calyx, and then you see that stone. Now you can see that this stone is very well seen. You are quite happy with it. The stone is located into the lower calyx. But see the position of the ureteroscope. It is not actually coming out. It is a vertically oriented scope. And when you have a vertical orientation of a scope, what you do is that common practice, what we do is that we engage the basket, engage the stone with the basket, and when we try to pull the ureteroscope down, what happens is that when you pull this ureteroscope down, naturally this part of the ureteroscope is going to go up like this on the laterally, because that's a natural physics. When you pull it down, that part is going to go laterally, and then laterally, since there is no space, it is not going to go, and if you pull further down, it will slip out of the infundibulum. So that is what is the common problem. That is what is the common trouble which is faced by almost everybody. So in a situation like this, what you do is that never pull this ureteroscope down like this. Instead, once you engage the stone, what you do is actually you push the ureteroscope up into the calyx. So what happens is that you push the ureteroscope shaft from here. So with this also goes up. And because it is vertically oriented, this arm of the ureteroscope, which is actually into the calyx, also comes out. It is parallel to the calyx, and that is how the stone comes out without slippage of stone out of the basket and without it getting hampered with the infundibulum. So that is a very common trick which has to be done, and that is a very important troubleshooting aspect when you can't relocate, when you can't engage the stone, and that is how you overcome this problem. If everything is not possible, then what you have to do is the in situ fragmentation. With the advent of the smaller fibers, it is possible to go into the lower calyx even with the laser fiber in position, and then you fragment. But the important thing is that never insert fiber in the bent position of ureteroscope. You will damage the ureteroscope. Make sure that laser is always projected outside and insulation is seen. Only while breaking the stone, make laser ready. Otherwise, there is always keep it standby. And bigger fiber, if you have fiber 360 micron, even 240 micron, it will hamper the bending of the ureteroscope, and you will not be able to go into the desired calyx which you want to go. And this is what has happened here. It is showing that this is a common problem which you face, that you have gone into the calyx, you saw that stone into the lower calyx without anything in position, but now you have put a laser fiber. So there is a little restriction of the deflection what you are going to get. Now engagement was not possible, the stone relocation was not possible, and therefore the in situ fragmentation was tried. Now because there is a limitation of the bending of the scope, what is happening here is that laser actually is not touching the stone. It is just touching at the side of the stone. And whatever you do, the main stone is not getting fragmented. You are touching and trying to break the stone, but in the process you have touched everywhere else except the stone. You see that there are multiple holes which are created because of the laser fragmentation or laser firing, which is actually gone to the mucosa, and that is what is the situation. So this is a common problem. Why this problem has occurred, and there is nothing you can do about it. What you can do is that how to overcome this problem is that now see this situation. This is another situation where the laser fragmentation is tried. There is a stone which is located on the medial side, and now the laser fiber is coming from the lateral side, say from 11 o'clock side, and moment you go and near the stone, there is no problem of bending. But moment you go near the stone, actually speaking, it is not touching, and just because the calyx is very short, moment you still bend the scope further, the scope is coming out and everything is going out of vision. Now this is also a common problem which will come. So there was a problem where you will not be able to touch the stone because of the bend. This is another problem where you can bend, but the shallow calyx, and therefore you are not able to go into the calyx. Now suppose in this case, if the fiber, this is a external pressure applied, but still it is nothing is happening. If this fiber was coming from here, it would not have any problem. It would have been broken quite properly. Even in the previous case, if the fiber was coming from this side, it would have touched the stone, it would have broken without any problem. So another trouble which comes in and which you have to be aware of is the exit location of the fiber. Now, if you see the different ureteroscopes, every ureteroscope or every company has their own design from where the exit location, the laser tip will come. Stores, it typically comes from the 3 o'clock. In Olympus, it comes from the 9 o'clock. It Wolf comes from the 9 o'clock. And in Biorad, it comes from the 11 o'clock. It all depends from the different make to make. But the advantage is that in a situation like this, in the first case, which we saw the video, if the laser tip was coming from the from a 9 o'clock position, the stone would have got fragmented. In second video, if the laser fiber was coming from 3 o'clock, it would have touched the stone and it would have fragmented. So that is what is the problem, and therefore you have to be aware that there are different makes and different design, different locations which are available. Another trouble which will come is the snowstorm effect. So what is it? Nowadays we are told that when we are dusting the stone, that is what is the standard teaching, is that you need to have a laser setting in such a way that you keep as low power as possible and as high frequency as possible. With the thulium fiber, you have frequency of 200, 500 and more than that. But as you increase your frequency, this is what happens, is that your vision temporarily actually becomes very, it becomes blur. Because there are powders which is created or a stone which gets fragmented and dusted, because of the increased frequency, it actually spoils the vision. And therefore you are not able to continue your laser fragmentation for significant period of time continuously. So what you do, the troubleshooting is that when you fragment the stone or when you press the paddle, press it temporarily, so stone gets fragmented, then wait for some time. All that dust will settle down. Again do fragmentation, again wait for some time, again it will settle down. So in a short burst, you have to dust the stone completely. So that is what is shown here, that you have this white snowstorm effect. Now you wait for some time, everything becomes clear. Then again you start pressing the paddle and stone can be broken completely and can be dusted completely. In anomalous kidney, there are more problems because you have the double curve. What do you mean by double curve? That when you have a pelvic ectopic kidney, first and foremost, you have to negotiate the natural course of the ureter. If the kidney is going more on the medial side, then that is what is the curve. And then you see here that there is one curve here and there is another curve here. You have to go here in the lower calyx. So you have this curve which comes, and then this comes which comes, and then ultimately you have to bend and go into that calyx. So that sometimes becomes very difficult to manipulate. If you have to manipulate and negotiate these multiple curves and do laser fragmentation or relocation, that becomes difficult, and therefore instead of breaking in that situation, it is always good idea to relocate that stone from that calyx, especially when you are dealing with the ectopic kidney with multiple curves. Now here that stone is being relocated, you catch the stone, and once you catch that stone, because there was a lot of space, it could be caught properly, and then you push the stone in the appropriate way. Here you can see that the stone is being pushed far off. When you catch the stone in the basket, don't just leave in the pelvis. That is another problem or another troubleshooting. That if you relocate that stone, put into the pelvis and start fragmenting is not correct. Because moment you start fragmenting, again the stone will go back into the fragments will go back into the same calyx. Once you take it out from the lower calyx, put into some calyx, either middle calyx or upper calyx, deep into the calyx, so that when you are breaking, the scope itself will block that infundibulum, and now you have a stone which is there in the calyx. The infundibulum is blocked by the scope, and now you can fragment the stone completely and without any problem. So other thing is that this is what has happened. What has happened is that when you fragment the stone in the pelvis or in the calyx, and if it is a larger stone, a lot of fragments actually come into the access sheath. And this is what happens, that when you are using reusable access sheath, you always have trouble. That when you take out the stone actually peel away the sheath, it damages the sheath. And once this damages the sheath, the leak happens, and then this scope actually becomes useless for reusing. So when you have fragmented stone, significant fragments which are there, and if you think that they are actually come into the access sheath, what you have to do is that don't just take out this sheath or pull the ureteroscope like that. Very likely that you may damage the sheath of the ureteroscope. Instead, by the side of the ureteroscope, with a ureteric catheter or with the syringe or with the adapter, just inject saline, so that whatever fragments which are there eventually go back into the kidney. And once you keep injecting saline, along with the saline push, keep on withdrawing the ureteroscope, so that will prevent the damage of the ureteroscope. When we were using the reusable scope, the leak test was very important, because when you are breaking the stone, when you are fragmenting the stone, some micro tears occur, some significant leaks which are occur, and that is not seen by naked eye, and therefore leak test becomes very important. Now what is shown here is that once you inject a pressure, if the pressure goes down, that means there is a leak somewhere. Why you want to see that whether leak is there or not? Because if the leak is there, that means there is some leak or tear in the sheath, and you see here you detect that sheath, detect that leak. If you continue to use this ureteroscope, then the water will seep in, and then the optics will start getting damaged. The fibers which are there inside will actually get damaged, and ureteroscope will deteriorate further. If you stop at this point and your vision is good, then repairing the sheath is not a big problem. It is not a costly affair. But if you don't identify this and continue to use ureteroscope, and in the process you damage the optical fibers, then you have a lot of expenses which are involved, and the whole ureteroscope may need to be replaced. And therefore, when you are using reusable scope, it is important that you do this leak test. Now, after damaging and after repenting and after burning our fingers, we have realized that actually the cost of ureteroscope previously was a cost involved. We have seen that ureteroscope can get damaged in 2, 5, 10, 20 uses, and then this 4 lakhs, 5 lakhs scope actually becomes useless. It's not a viable investment at all. So if you see the cost of the reusable scopes is too high. If you go for the digital, for the higher quality reusable scope, either Stars or the Olympus, the cost is escalating. And therefore, for last 2, 3, 4 years, the disposable scopes have come, and that has completely changed the scenario. If you see the disposable ureteroscope, the main scopes which are there in the market, LithoView, that's Boston Scientific, Busan, that is Chinese, Biorad, that's Indian, and UMD, which has come recently. They have different timings. The LithoView The light will last for 4 hours, BUSCON for 4 hours, Biorad for 21 hours, and UMD now are claiming that there is no limit, there is no time limit for them. The scopes are quite much cheaper, and if you negotiate with them and you buy in bulk, they are much, much cheaper. And if you see the cost of ureteroscopy, because when we are talking about troubleshooting, important aspect is that every procedure has to become cost viable. Whether you are working in a corporate hospital, whether you are individual practice, or whether you are in government sector, cost is very, very important factor. And if you see the reusable cost, STARS or the Olympus, if you use that same scope for 50, 60 uses, 100 uses, then STARS you will spend 4,000 rupees per case. That is just on the scope. Whereas in Olympus P7, you will spend 6,000 rupees per scope. However, if you use disposable scope and if you use Biorad and if you use optimally, then your cost per scope is going to be considerably less. And we have been now using disposable ureteroscope, and what I feel is that disposable flexible ureteroscope, thulium fiber laser, which is much smaller in the 150 microns, will reduce the cost significantly. Why? Because with these smaller fibers, you can actually fragment the lower callosial stones also in situ, and therefore need for the basket actually has gone down. These baskets are very delicate, they are very expensive, and with just 1 or 2 uses, they will become actually useless for subsequent use. And therefore, when we talk of the cost of the ureteroscopy procedure, if you have to include this basket cost, it becomes quite high. And therefore, previously, why the ureteroscopy or flexible ureteroscopy was not so popular, mini perc was much, much better, because the cost involved was actually unviable. But with the advent of the flexible ureteroscope, in fact, the Biorad scopes which we are using, we have used one single scope for more than 50 uses. So it lasts quite long. The vision is quite good. You get the digital quality vision. You have the thulium fiber, which is 150 micron size, can come. You have no need of baskets and other things. And with this advent, your RIRS actually has become much more cost efficient procedure. Previously, we were talking that RIRS is actually should be reserved only for the consultant, only for this. Now, with the disposable ureteroscopy available, with the thulium fiber laser or with the smaller fiber, in fact, RIRS has become much cost beneficial procedure. It is much less cost, and therefore I feel disposable flexible ureteroscope is a game changer. And with this, RIRS is going to be a mainstay in the management of the ureteroscopy. And that is what I wanted to tell about the troubleshooting in RIRS. Once again, I thank the organizers for asking me to be the part of this oration. And in fact, this conference was planned last month, but because of this COVID third wave, it got postponed. And incidentally, this is my first physical conference after I take over as a president. So generally, everything first you remember, your first car, your everything first you remember. So I certainly will remember this conference, that as a president, I attended first conference of the Bengal Urology Society. So I am really proud and privileged to be part of this particular conference. Thank you very much.
Thank you, sir.